Hello and welcome to Tell Me Fast About Stroke. This is Suzanne de Beaumont from NYAIL, the Open Doors program, and today we have presenting Laura Bingell from the Transition Center, and joining us as well is Christine Trimboli, who also would be able to answer questions. So without further ado, Laura, take it away.
Thank you. Hello, everybody. Today we will spend some time on what a stroke is, risk factors and prevention, how to recognize it when it's happening, diagnosis, treatments, ways that it can affect a person's ability to function, and long-term implications. The functional and long-term implications are what I suspect is most relevant to transition specialists in performing their jobs, and we will discuss these issues. But I also want to spend some time giving information to you to broaden your knowledge and understanding. I've met many of you at the conventions, so I know this is the kind of people you are. You're kind people, eager to know more and willing to really exert yourselves for the people that you're assisting. So it's my sincere hope that you'll gain something from my presentation today. So let's start with slide 1. A stroke occurs when a blood vessel that carries oxygen and nutrients to the brain is blocked or bursts so that part of the brain does not get adequate circulation and brain cells die. A CVA you may see in medical records is a cerebral vascular accident. This is the most common medical term you'll see. It can be a cerebral infarct or a cerebral hemorrhage. Cerebral having to do with the brain, infarct, a small localized area of dead tissue resulting from failure of blood supply. And this is often because of a clot or an embolism. And hemorrhage, I think everyone knows what that is. So TIA is another medical term you will see. It is a transient ischemic attack. Transient meaning lasting for a short period of time or not permanent. And medically, this means symptoms are lasting less than 24 hours. Ischemia is a restriction in blood supply causing a shortage of oxygen needed to keep tissue alive. So the tissue essentially starves for oxygen. In the next slide, we'll see that there are two forms of stroke. And the ischemic stroke is by far the most common, causing 80% of strokes. It's caused by a blood clot or plaque formation that obstructs blood flow to an area of the brain. And obstructions can be from an embolism, which forms somewhere else in the body and then travels and lodges in a smaller vessel, in the brain in this case. Or when hypertension breaks a clot free from a larger vessel, this can happen as well. Or it can be what is called thrombotic, which means it forms in a vessel of the brain, such as in plaque buildup from high cholesterol. The second type, pictured on the right-hand side of the screen, is hemorrhagic, causing 20% of strokes. Uncontrolled hypertension is the most common trigger. A weak vessel leaks or bursts from increased pressure, and then the increased pressure from bleeding into the skull, a confined space, decreases the ability of blood to flow through the vessels and get oxygen and nutrients to brain tissue. So, of course, stopping bleeding and reducing pressure is of the foremost and immediate concern. Next slide, please. In the United States, each year 800,000 people suffer from a stroke, and within 5 years, 25% of these will have another. And there are 7 million stroke survivors currently residing here in the United States. In 2015, it caused more than 130,500 deaths, making it in the top 10 ranked causes of death. It's currently ranked at number 5. So every 4 minutes, someone dies from a stroke. So looking at my watch, it just turned 1:05. Since we started this webinar, someone has died from a stroke. It is a leading cause of disability for adults in the United States. Of the survivors, about 1/3 will have mild impairments, 1/3 moderate, and 1/3 will become severely impaired as a result of a stroke. Next slide, please. So you may wonder what disabilities frequently happen with stroke. Although a stroke is a condition of the brain controls the function of the entire body, as we all know. So a stroke can have lasting effects on any function of the body. Hemiplegia is one that we will see often, and this means one-sided paralysis. Hemiparesis, one-sided weakness. Aphasia, which is difficulty with language and communication, and we'll talk more about this later in the presentation. And it can be expressive or receptive or both. And as within a traumatic brain injury or any type of brain injury, you can have any of these symptoms that we are all familiar with: emotional, memory, depression, impaired judgment. They all can go along with it. Stroke survivors may suffer from chronic pain syndromes, numbness or strange sensations with pain that is often worse in the hands and feet and made worse by movement and temperature changes. This is characteristic of neurogenic or nerve pain. And along with more obvious motor impairments can be loss of continence and loss of sexual function. In fact, any medical issue must be looked at as potentially being related to the stroke. And this is something that the medical community sometimes needs help remembering. Good news in this area is that in September 2011, the American Board of Medical Specialties approved the application, a joint application from the American Board of Psychiatry and Neurology and the American Board of Physical Medicine and Rehabilitation to offer subspecialty certification in brain injury medicine. Since 2014, there are only 4 certified in New York State, but hopefully there will be more. This does not mean that a neurologist or psychiatrist without the certification are not good or don't have adequate experience, especially since it's relatively new. However, it's my feeling that certifications such as these steer us towards a higher standard of care and accountability. So it's never wrong for a consumer to ask a medical practitioner about their credentials or additional trainings they've benefited from or certifications, or how many people with similar diagnoses or circumstances they've treated. It's very much like asking them, have they washed their hands before they administer any kind of treatment to you? If they become offended, you don't want them. Next slide, please. The brain is so amazing and complex, but our time today is limited. So this is pretty simplified to just give an idea of how profound the effects of damage to it can be. Basically, the cerebrum of the brain is higher functioning, and that controls, as you can see in the slide, voluntary motor coordination, reasoning, planning, emotionals, many of our senses such as touch and perception, much of hearing and smell. And then in the occipital or back part of the brain, sight, and we'll talk about that some later as well. The cerebellum controls balance, posture, motor coordination, and motor memory. And this means like your ability to ride a bike after you've learned without thinking about it. But also this part of the brain has a role in cognitive functioning. And maybe it can be thought of kind of like the SD card that expands the functionality of your smartphone, storing things that you don't use all the time but might need later. Although it does have many functions of its own, as we already discussed. But its role in higher functioning is still not fully understood. The brainstem, beneath that, is basic functions, those that we don't think about to produce, but still are very important, like our heartbeat, digestion, breathing, and reflexes. So what long-term effects a person has will depend upon the area of the brain that has been damaged and how severe the damage is. Next slide, please. Personality changes are not uncommon after a stroke, since each side or hemisphere of the brain has primary oversight of different aspects of character and personality. This also means that the impact on a person is very individualized and can be difficult for close family and friends. Their personality may actually change. A person who makes their living as an accountant may, for instance, not have as big of an adjustment after a right brain stroke as an art critic would. So very, very individualized. Next slide. And this slide is a very good demonstration of why I am a nurse and not an art critic. I couldn't find a very good picture of this, so I did a cookie cutter, and here you go. So each of the two hemispheres of the brain processes the neural information crossing from the opposite side of the body. This is the opposite side of the body from where the sensation originates. For example, your right arm is controlled and information is received from it by the left hemisphere of your brain. And this is why lasting effects are often one-sided. The two hemispheres do communicate with each other through a network-like structure called the corpus callosum. And this means that the hemispheres are not entirely separate individuals, and we can be glad for that. For some people, this communication is more obvious than for others. A person who is a concert pianist typically would be using both hands on the piano, so both sides of the brain must relay information on artistic interpretation to each hand from the right brain. So think how this would affect a person if the corpus callosum is damaged. It can cause a condition known as split brain. The left hand literally does not know what the right hand is doing. And a very potent example of this was the man after suffering a stroke who fought with his right hand trying to dress his body at the same time his left hand was working to undress it. And just imagine how frustrating that could be for an individual. In a diffuse brain injury, where damage is scattered throughout both sides of the brain, this can cause reduced thinking ability and speed, reduced attention and concentration, among other things. Next slide. Risk factors typically fall into three categories. Under conditions, I would like to highlight 2 points. First, that total cholesterol should be less than 200. LDL below 130, and many physicians prefer it even lower after a stroke. HDL greater than 50, triglycerides below 150. And so if anyone doesn't know what their cholesterol level is, it's a good thing to know, just like it's good to know what your blood pressure is running. A way to remember which cholesterol is good and which is bad is L is lousy and H is happy. Kind of simplifies it for us. And the second one under conditions, about 10% of people that present with acute ischemic stroke, or TIA, will have a new atrial fibrillation diagnosis during their hospitalization. So this is a very prevalent cause of an ischemic stroke. Regarding behaviors, first, exposure to secondhand smoke must be included in tobacco use. And secondly, it is estimated that the reductions in people with diabetes, hypertension, and hyperlipidemia associated with a 10% weight loss for obese people could lead to reductions of stroke of up to 13 per 1,000 people. So these are recurring things that we constantly see in how to minimize risk factors, and we can help people by educating them to this. Under other, the chance of having a stroke close to doubles every 10 years after age 55, so we need to be aware of that. And there are ethnic considerations. African, Hispanic, Native American, or Alaskan heritage have higher risks of having a stroke than those with European or Asian ancestry. Next slide. Next slide, please.
Sorry, I'm trying to get it to go. Oh, there you go.
Okay, very good. Maybe it was having a little TIA.
There you go.
Okay, so this is a very nice acronym, since we're all from the world of acronyms, FAST, from the American Heart Association. It's a way to remember the symptoms of stroke and what to do. F for face. Do both sides of the face move equally? This is normal. Or does one side of the face not move at all, or droop? Of course, abnormal. Arms, ask the person to raise both arms. Do their arms move equally, or does one arm drift downward compared to the other, as in the picture? Speech, ask the person to speak a simple sentence. Do they use correct words with no slurring, or does their speech slur, or do they use inappropriate words, or are they unable to speak at all? In T, if any of these symptoms are noted, it's time to call 911 immediately. And as we'll discuss a little bit more in later slides, it is imperative every minute, every second really does count in order to get treatment quickly and get the best possible outcome. Next slide, please. And this is true even if symptoms go away. Symptoms of a TIA are the same as a stroke, but can resolve within minutes or hours. But up to 40% of TIA patients will go on to suffer a stroke. Medical management of TIA is focused on preventing a future stroke. So it's a warning for people. And it's very important to seek immediate medical attention if you suspect a TIA. In fact, 5% of people who have TIAs will have a stroke within 2 days, and 10 to 15% will go on to suffer a stroke within 90 days. So you can see how important that is to get that. Other symptoms of a stroke that we did not say in the previous slide have to do with vision, double vision difficulty, dizziness, trouble walking, loss of balance, or a sudden severe headache with no known cause. So that just merits mentioning. Okay, next slide. These times for the phases of a stroke are a broad guideline. You can see variations depending on your source, but this put it into a little bit of a picture with some general guidelines. The hyperacute phase, first 6 hours, is typically signs of first symptom into the emergency department visit. The acute phase is typically hospitalization. Subacute would be during close monitoring, starting new treatment, recovering, and having rehab. And you'll notice the 15 to 20% there. In the subacute time frame of ischemic stroke, there's a higher risk for what is called a hemorrhagic transformation. And of course, this means bleeding into the brain as a result of the trauma it sustained. And this can occur within about 15 to 20% of cases. Statistics even indicate that the cause of death for those who die from ischemic stroke during that subacute phase is typically from this hemorrhagic transformation. And this is why close monitoring is necessary for good outcomes. And stroke centers are really in the best position to do this. The next slide. The New York State Department of Health has a very nice page on their website, of course, amongst all of their informational pages. But this one is basically where the stroke centers are in New York State. And I've put in some numbers there, and you know, larger, more populated counties typically have more available, which is a good thing. But you'll notice in our northeastern portion, New York State, there's a little bit of a shortage. So some of the people in the rurals are again going to suffer from the lack of needed health care. And I put in some random points in these counties and Google mapped it, and these people are really pushing it to get to a stroke center within the 3-hour time frame that is recommended. So for people in these areas, probably the best thing to do would be to go to the nearest emergency department, get stabilized, and then shipped out if needed. And it could be shipped out by medevac or by, you know, by helicopter, and still get to a stroke center if that would be the best course for them. So, Christine, you work a lot in these rural communities, don't you?
Yes, actually, I do spend a fair amount of time, especially in northern Warren County, Essex, parts of Hamilton, Clinton, and Franklin. And you're right, they really are isolated, and especially Essex County and Clinton and parts of Franklin are actually airlifted once they're stabilized from local hospital to Burlington, Vermont, which is the closest designated stroke hospital to that region. The lower portion that you have outlined, parts of Warren, Saratoga, Fulton, and Lower Hamilton would go to Albany. But the time frame is really critical from when the families first notice that their loved one is having stroke symptoms, because the protocol and treatment is based on how much time. There are certain things. There's a treatment called TPA, for example, and that can only be instituted if it's been less than 3 hours from the onset of symptoms. So the one last thing I'll add to this is the designated stroke centers in New York train the local EMS providers very, very well with all the different protocols. And since we're talking obviously about stroke here, there's a designated stroke protocol that they are instructed to follow. So there really is good communication with these designated stroke centers and the EMS personnel in New York.
Thank you. Okay, we can move on to the next slide. So a stroke is diagnosed by the physician obtaining medical history, doing a physical exam, of course procedures, which are primarily x-rays or radiographs, blood work, and very many times heart studies. A CT is almost always done first, although that's not the picture I have on this slide. This is an arteriogram, and it's a study of the blood flow through the large vessels, which can be done by CT or MRI. And it can show precisely what vessel is blocked. This can give a very good idea of what effects can be expected. If we know where in the brain the stroke occurred, we also know what functions that portion of the brain is in control of. So it can be very helpful for long consultation. Next slide, please. So this is the CT. Suzanne, I'm getting some feedback.
Yeah, I'm hearing it as well.
Okay.
I can hear. I'm not getting any now. What are you?
Okay. No, I still am. Do we need to mute this?
Do you have anything open on your computer that's not the webinar?
Just email.
So just try closing that out.
Okay. It's gone.
Now
All right.
Is that better?
I'll proceed and we'll see how we go. Okay. So the CT, as I mentioned, is usually done first because it is an adequate image, and in most cases has overall lower costs. It's about half that of an MRI. Has better availability and can be much quicker, which we already mentioned is very important. However, during the first 6 hours of symptoms, there's a debate at how sensitive a CT is. A normal brain CT during this period does not entirely rule out the presence of an ischemic stroke. It just may not show up yet. So depending on the results of the CT and the way that the person presents, the doctor may wish to obtain additional testing, including an MRI. And I thought this would be interesting for you, just to give you an idea of how the CT actually works and shows the picture. The CT is based on the principles as a regular X-ray. They're absorbed differently by the different parts of the body. Bone absorbs the most X-rays, so the skull appears white on the image. Water, as in the center part of the brain, which is the ventricles, which are fluid-filled cavities in the middle of the brain, absorbs very little, so appears black. The brain itself has intermediate density and so appears gray. Most ischemic strokes are less dense, so would appear darker than normal brain, whereas blood in a hemorrhage, as on the right-hand side, is denser and would look white on the CT. So that's what you're looking at there.
So what's the black part on the ischemic?
On the ischemic, the black part is actually the tissue that has been affected by the stroke that was not getting enough oxygenation.
And then on the
And
hemorrhagic, the white part is actually the blood.
that's the bleeding into the brain. And an interesting thing about the hemorrhagic as well, as you'll notice that the symmetry of the brain has been disturbed, shifting it to the right-hand side. That's called a midline shift, and it's because of the pressure from the bleeding into the skull on the left-hand side. Next slide, please. Here is what an MRI would look like, and you can see it is a clearer picture. So it can be useful in providing a more detailed image, but it does take longer to perform, and timing from onset of symptoms is crucial for treatment. It might not be available under emergency conditions, or a person may be unable to use it because of metal in their body or other reasons that it would be contraindicated. Also, to consider, CT images may appear normal in the first 6 hours or show only subtle changes that might be too small to be seen, or maybe in a part of the brain, such as the brainstem or cerebellum, that the CT scan does not image well. And you'll notice on the right that even TIAs, though often very small, will show up on an MRI about 1/3 of the time. So again, stroke center physicians are in the best position to inform individuals and their families of the risks and benefits and supply educated recommendations as to which procedure is going to be best for them in their particular circumstances. So as far as how an MRI works, which you may be interested in this as well, the machine creates a magnetic field which briefly alters the water molecules in the tissue being imaged. The response to this magnetic field is then detected and used to create an image of the brain in this case. During the exam, a radio signal is turned on in bursts, and the energy is absorbed differently by the different tissues. This energy is reflected out of the body and detected by the MRI scanner. A digital computer then constructs these reflections into a picture. Pretty complicated, isn't it? So the switching on and off of the device that measures the reflected signals, called the gradient coils, this is what you hear when you get an MRI and you hear that loud, disconcerting knocking.
Laura, there was a question, I apologize, I missed it earlier, asking about the stroke centers and if there was any plans to expand the stroke centers into that sort of large North Country area with no services.
You know, probably not, because stroke centers are basically hospitals, and hospitals have to meet the bottom line. And there's probably very few of them that can put the money into getting all the equipment that they need in order to be fully certified. So population and the way that tax money is given out and grants and all that kind of thing, probably no plans, because it's not something that can just be miraculously put there. It would have to be funded.
And there's no thoughts or plans for funding that, right?
Not that I'm aware of, but I mean, it is something that people could write their senator about.
All right, I think that answered the question.
Okay, I'm ready to go to the next slide. So, people who have had a stroke sometimes experience very remarkable and unanticipated recoveries that really defy explanation, and I'm so glad for that. The brain and spinal tissue are so remarkable in so many ways, such as in their ability to regenerate. Some brain cells may only be temporarily damaged and may resume functioning, and some may be able to relearn functions. Sometimes another area of the brain can compensate for an area that's been lost. So these recovery percentages are a general expectation from known outcomes. So as we mentioned before, a very high number, up to 1/3 of people who survive a stroke, do end up with very severe impairments, which would qualify in that special care area. Okay. Prevention is the cornerstone. Whoops. Did I hear somebody? Okay. Prevention is the cornerstone of stroke treatment. As in anything else, prevention is so important. People need to work with primary care doctors to manage and identify risk factors. This includes treatment of high blood pressure, heart disease, smoking cessation, dietary management, especially for those with conditions like diabetes, and taking medications as prescribed. And the ones that come to mind are for diabetes, hypertension, atrial fibrillation, and any kind of clotting disorder. Hypertension is a prime factor in the majority of ischemic strokes. Anything above 140/90 is hypertension. Anything above 120/80 is pre-hypertension. And these are pretty strict guidelines, as even up to 15 years ago, we thought 120/80 was pretty good, but it's not anymore. It's preferred now that your second number, the 80, is a bit lower. 60s to 70s is better. And according to the new dietary guidelines just published this past year, one of the main factors for that, other than obesity, as we keep coming back to in every webinar we do, is that the American population generally eats way too much salt. The recommendations are 2,300 milligrams a day or less. And if a person is over 51, knows they have a chronic condition like hypertension, diabetes, or kidney disease, or if they are African American, it should be 1,500 milligrams or less. So very strict guidelines. No added salt, really. So when they did a study of this, just interesting side point, the CDC reported from a national survey of almost 35,000 people between the years of 2003 and 2010, the average American consumes 3,400 milligrams of sodium a day. So this being way above the 2,300 that's now recommended. Okay, next slide. Strict criteria are followed by medical teams in determining if a drug or a procedure can be used to reopen an artery to allow blood flow to the brain again. When a clot is responsible, beginning in 1996, clot busters, or as Christina already mentioned, TPA, can be delivered through a vein over the course of an hour, but this must happen within 3 hours of the first sign of stroke. Even when blood flow is restored, there still may be permanent injury to the brain, but the sooner treatment starts, the better the outcomes are. It's good to remember that treatment during this time is very individualized. Doctors are working to prevent rebleeding, hemorrhagic transformation, and to keep new clots from developing in either type of stroke. In order to walk this tightrope, they rely on well-established clinical guidelines. The chest antithrombotic guidelines from the American College of Chest Physicians is one of the best known and most trusted resources in this regard for the medical community. It keeps current on new medical findings and provides up-to-date recommendations for prevention, diagnosis, and treatment of a comprehensive list of blood clot-related clinical conditions, stroke being among them. So, those offered any of these procedures that are listed here must be carefully screened so that benefits outweigh the risks involved, because each one of them has risks. So this was interesting, that last part there too, the umbrella. It'll be nice to see how that works out. It's so new, and they're kind of touting it as the I wrote it down here, as the non-drug alternative to warfarin. But when things are this new, I always kind of stay on the side of caution. We'll have to see what works with that. Okay, next slide. As far as medications go, even something as simple as aspirin can have a beneficial effect. By using aspirin, a reduction of up to 20% of risks for stroke sufferers for having another can be obtained, and anticoagulants by up to 80%. But people who are likely to fall, are at increased risk of problems from bleeding, or can't remember medication is prescribed, probably won't be prescribed an anticoagulant. For them, aspirin is the safest choice. And it is usually recommended that patients start an aspirin regimen within 48 hours of an ischemic stroke. But again, treatment is highly variable. Strokes caused by an irregular heart rhythm called atrial fibrillation often require to be on blood thinners, and this is why the heart testing may be ordered. The factor Xa inhibitors, which you've probably seen commercials for on the TV, have shown particular benefit for people with atrial fibrillation that's not caused by a heart valve problem, and this over warfarin in many studies. But it's still not FDA approved for other situations. So studies are also being conducted in how to best use antiplatelet medications alone or in combination. So the jury is still out on this. And while we wait for these final outcomes of these studies, we'll continue to see commercials one day telling us how wonderful a new medicine is, especially if you golf. And then right after, we'll hear the message from the law firm that wants to represent you if someone you know has been injured by it. So just stay tuned on those. This is something important as far as managing a person in your caseload would go. Costs of medications can vary greatly. So people need to research their insurance formularies to determine that the out-of-pocket costs are not out of reach for them. So I always recommend to people that they take a copy of their insurance pharmacy formulary along with them to any doctor's appointments, or have the doctor access it online using their insurance card. This way it can be used during the decision period in choosing an appropriate medication that is also going to be affordable. And for your information, the web address at the bottom of this page is on the coagulation cascade for anyone who wants to do additional research. This is the complex physiological process of blood clotting by several different mechanisms to maintain the integrity of the circulatory system when it is damaged. There are several different pathways for clotting to occur. Plan A, Plan B, so to speak, and so then there is more than one way to slow or prevent it. Coumadin, warfarin, works by inhibiting vitamin K-dependent coagulation factors, and it has been in use since the 1950s. You're probably all familiar with that. It requires more frequent blood monitoring, but it's easily reversed with a dose of vitamin K when needed, such as in an emergency. The factor Xa inhibitors, like the Xarelto, Eliquis, and Pradaxa, requires less frequent lab tests, which is what people like, but reliable reversal remains an issue at this point. So it could pose a problem in an emergency. Say a person on one of these was in a car accident or needed emergency surgery, such as an appendectomy. There are antidotes in late trial and an FDA review presently, but not yet approved. Next slide. After stroke, individuals and their families are often concerned about being on their own at home. They face many new issues in daily living skills, dressing and grooming, nutrition and eating, skincare, chronic pain, changes in intimacy, behavior, communication, grieving, emotional ability, memory loss, and having no or diminished awareness of one side of the body. This is a syndrome called one-sided neglect. Okay, we can move on. It's common for stroke rehabilitation to start as soon as 24 to 48 hours after a stroke during the acute hospital stay. Sooner is better if acute medical problems don't prohibit it. And options for ongoing rehabilitation can include inpatient rehabilitation units, which are facilities that are either freestanding or part of a larger hospital or clinic, and the stay may last for several weeks as part of an intensive program. Outpatient units are often part of a hospital or clinic, and individuals can spend several hours a day in rehab but return home each night. In regards to skilled nursing facilities, some specialize in rehabilitation while others offer less intense therapy options and more custodial care. I really suggest that people research and choose carefully rehabilitation centers, because being called a rehab center doesn't necessarily mean that they're good at. And I know that you've all visited many places, so you know what I'm talking about. The web address that is provided there, again from the DOH, is a good resource for looking at specific facilities and seeing how they're rated in comparison, and you can pull them out by region or by county, and if they've had bad reviews, you're going to know right away.
Laura, do you get bad reviews by the Department of Health or by patients?
You can get either way. It can go either way. You can get personal reviews from people, but you also can get access to, say, their JACO, how they came out when the state actually sent the agency in to review their care and where they needed to make improvements.
All right, and that would speak specifically to things like bed sores and, right?
They cover a broad range of things that nursing homes in New York State are expected to provide for people, from quality of life to actual medical care and medications, that kind of thing. It's a very comprehensive review that they do when they go in. And when they don't do well on this, nursing homes, having worked in a nursing home in the past, for the serious ones, it really does tend to snap them into shape, and they make changes quickly if they want to stay open.
Oh, good. That's good.
Yes, Laura, I'd like to add something here.
Sure.
The nursing homes are usually given a correction plan that they have to follow and rectify as outlined by the Department of Health, and they're given so long to do this, and then they're re-inspected.
Yes, that's right. I remember that from years ago. Okay. As far as home-based programs for rehabilitation go, for some people this may be the way to go. It does offer greater flexibility, but there are some drawbacks as well. And one of the biggest ones could be limited access to specialized equipment. And in line with that as well, we must consider that insurances strictly control who qualifies for home-based therapies. So there may be therapy caps that individuals need to be aware of. And hospital discharge planners should be able to assist with this concern. Excuse me. Next slide, please. Okay, physical therapy. I'm going to break usual therapies into their most basic components because there's no way to cover everything that therapists do. It's good to remember that many of a person's rehabilitation needs can be met in a variety of settings. For instance, PT and OT very often work closely together on some of the same issues. OT and ST, or speech therapy, are often working very closely together on some of the same issues. So it's important to remember that. In physical therapy specifically, though, repetitive practice is very important. It's the same kind of practice used by all of us when we're trying to learn a new skill, such as playing the piano. We have to practice our scales, or riding a bike, practice. For many stroke survivors, rehabilitation will be an ongoing process to maintain and refine these, and this could involve working with specialists for months or years after the stroke. And as we mentioned before, sometimes a stroke survivor may lack awareness of space on one side of the body. For instance, a woman who was noted after the stroke of putting makeup on one side of her face can be assisted by physical therapists to regain awareness of stimuli on the neglected side of their bodies. Next slide. Occupational therapists often help people to divide a complex activity into smaller component parts and then practice each part and then perform the whole sequence of actions. So I did like the definition I found of occupational therapy, enabling individuals to develop the means to improve their function in the occupations of life. So that's the chief difference between PT and OT. The occupational therapy is focusing on daily occupations, whereas the physical therapist is focusing on independence and mobility. So occupational therapy can improve coordination and can help people with apraxia, which is difficulty with motor planning, to perform tasks or movements when desired. And some occupational therapists have additional training to assist in adapting or relearning how to drive. the American Occupational Therapy Association at www.aota.org, and that'll be listed in a resource slide at the end of the presentation. Under Productive Aging has some very nice resources in this regard. And they can help with neglect issues as well. For example, someone who's eating food from only one side of their dinner plate. They'll help to develop strategies and change elements of the environment that can limit activities of daily living, and it can be as simple as things that we all do as well, as far as advising installation of grab bars in the bathroom. Next slide. I won't spend a lot of time on this one because I think everyone listening knows about assistive devices, but basically, as many ADLs and IADLs as there are assistive devices and strategies. Being creative and determined is the key. Utilize trade, ideas from support groups, therapists, and any others with experience. And I've personally found online forums can be very helpful in evaluating devices before they're purchased, and in coming up with great do-it-yourself strategies. Some people independently come up with the best ideas for their own problems and can share. It's a wonderful resource. Next slide. Communication problems are among the most frustrating after effects of stroke for both the survivor and the family, and this often requires professional help. And imagine how frustrating it would be that you understand everything that's being said to you, but you're unable to say what you want in response, or it's always slurred, or sounds like a word salad, or you can't recall the right words, but you know them. This is what expressive aphasia is. In the case of receptive aphasia, you could look at it this way. Suddenly your native language seems like a foreign language to you. And I had to think it's a lot like the phenomenon that we all have experienced of going into a room for something and not remembering what we went there for, except it's in the process of our communication, and it doesn't happen once in a while. It's happening all the time. So it can be very, very frustrating to people. Speech-language pathologists help stroke survivors with aphasia relearn how to use language or develop alternative means of communications. And they can also work with patients to develop problem-solving and social skills needed to cope with alterations in this ability. They can assist with eating problems, including delayed swallowing, an inability to manipulate food with the tongue, or an inability to detect food still lodged in the cheeks after swallowing. Speech therapists pinpoint the problem and then work with the individual to devise strategies to overcome or minimize the impact on the person. And sometimes simply changing body position while eating, or improving posture, or changing the texture of foods can be what the person needs. Sometimes it's that simple, sometimes it's not. So generally though, I just want to put a plug in here for speech-language pathologists. I've never met one I didn't like. The profession really seems to attract good quality people. So I think you wanted to make a comment,
Laura?
on this, Christine? Yes.
Yeah, Laura, this is Christine. I wanted to make a comment going back to the expressive aphasia. And what a lot of people tend to forget is it's an acquired communication disorder that impairs the person's ability to process language, but it does not affect intelligence. I have to say it is so disheartening to see people who suffer from expressive aphasia sometimes being made fun of or ridiculed behind their back because, they sound like they're, intoxicated, or they're not intelligent, or that they have a mental illness, or it's in some way or other an impairment in their intelligence, which is the farthest from the truth, but it really is, it's sad, and it does occur. So I just wanted to, it's a pet peeve of mine, but anyway, I just wanted to throw that in there.
Thank you, nice observation. Okay, we'll proceed to the next slide, please. So in communicating with a person with aphasia, assistive devices like photos, diagrams, the old-fashioned pen and paper, gesturing and communication tools like an iPad may often be useful. If the person has lived with it for a while, follow their lead. They'll likely know what works best for them. If the person is young and dealing with the aphasia, they may get frustrated. Just be patient with each other and with yourselves. Repeating key thoughts back to them may provide them with reassurance that you're able to understand them, that you're following. And if people are not too frustrated at a particular time, of course, good-natured humor can also lighten up the time. Next slide, please. This was one of the best websites I found as a resource for people dealing with aphasia. I found it to be very user-friendly. It has pages for personal experience through blogs, apps, reviews, books, current research and events, forums, and a lot more. And Christine, when you and I talked about it, you said your daughter, who is in that field, was aware of this site?
Yes, she's a speech language therapist in a school, and she has mentioned the site to me before. It's very informative, full of good information, and I actually have it open on my screen right now. And every month they have a featured professional. And Laura, in an earlier slide, you had mentioned about the different therapies and speech, physical, OT, and how insurance runs out after X amount of treatments or sessions. Well, just an example of how helpful this site is, this month's featured professional talks about what to do after your insurance runs out for speech and physical therapy, and click here to find out. So in thinking this is a good thing for just good common knowledge for a transition specialist when you're meeting and following up with people after they've come back out into the community, and you hear, you may hear this, that, gee, my therapy is run out or whatever. So it's a great site. Check it out.
Thanks. Okay, moving on to the next one, which is recreational therapy. This is relatively new on the scene. And recreational therapy involves regaining enjoyable skills and pastimes, such as what we do every day: gardening, cooking, sewing, playing cards, helping people to regain lost or damaged thinking abilities and physical capabilities. And recreational therapists use a variety of techniques. I've listed some on the slide. And currently, only Oklahoma, North Carolina, Utah, and New Hampshire require licensure in this field, but most employers will not hire individuals who have not been certified by the National Council for Therapeutic Recreation. So it's a certified position in New York State now, not a licensed one, but that doesn't mean it won't be in the future. More coming on that. They're becoming available in more and more settings, so stay tuned. Next slide. About 1/3 of stroke survivors will have an effect on their vision. A left-sided stroke usually affects the right visual field in both eyes and vice versa. This is called homonymous hemianopia. Oh, good, I said it. 8 to 10% suffer this effect, and others can have tunnel vision where peripheral vision in each eye is lost. But sometimes recovery is possible of some of the vision, and this will usually stabilize within the first few months. However, if brainstem involvement is what caused the visual problems, this is usually due to perception problems rather than the function of the eye itself. And those are listed on the slide. A neuro-ophthalmologist has more advanced training in treating vision problems caused specifically by brain injury. And this is someone that typically has training in both fields, ophthalmology and neurology. So there is a national society for these, and their website helps patients to locate them in their own state. New York City has the vast majority in New York State, but each major university hospital seems to have at least one. When I did the search through their website, Buffalo, Rochester, Syracuse all did. Overall, there are 52 neuro-ophthalmologists in New York State currently practicing. Next slide.
So Laura, does that mean that kind of as a routine course, that transition specialists working with someone with strokes should be asking these questions? You know, are you able to see, you know, because it just occurs to me that it would be so easy to ask this question, and if the person says, oh yeah, I can't see anything on the right side, then you just stand or sit in a different place for them.
Right, it's a good thing to ask, and especially if the stroke is a couple months out, so that you would expect that they had recovered as much as they're going to. If their vision, if they still have especially perception problems, by seeing a neuro-ophthalmologist, there are strategies in place that can help with these perceptual problems that don't actually correct what's going on within the person's neural circuitry, if you will, but like, for instance, by putting prisms in the glasses to get rid of a blind spot, or you know, or there's other things as well. There's all kinds of strategies that may help them to be, for instance, less at risk for falling. Does that answer your question?
Yes.
Okay. All right, then next slide. A physiatrist is a medical doctor who has completed training in physical medicine and rehabilitation and may be subspecialty certified in brain injury and medicine. And the reason that I'm bringing up these specialties is because very often people just think a doctor's a doctor, and if they're seeing a doctor, you're okay. But sometimes just a family doctor doesn't have the resources or the extra training, and sometimes we need to be looking for a special doctor. So when we have a person with a stroke who has multiple needs or multiple medical problems, or whose recovery may be very involved over a very long period of time, a physiatrist can actually be the primary doctor to help coordinate all this care. And they too, as the others, have a special association. And when you read in their site, New York State has over 500 of these currently. And so it may be something that you would see.
And my experience with physiatrists is that a lot of times they'll work with the OT and the PT, and they'll give them very specific recommendations about what to do for a person with a brain injury.
Yes, and that can be true because of the fact that they are already in the specialty of physical medicine and rehabilitation. So they are geared toward rehabilitation, and then can be subspecialty certified in brain injury or that. And the other thing is you may see physiatrists that are MDs or DOs, and I know for a long time I questioned, what is a DO? It's an osteopathic doctor. Basically, it's the same general training, except that DOs in their core curriculum actually cover more of the holistic type of things about incorporating lifestyle and those kinds of things. Whereas if an allopathic or an MD, medical doctor that we're most frequently in association with, they tend to get this training afterwards if it's of interest to them, like naturopathic medicine or holistic medicines, those types of things. Whereas DOs are exposed to it within their primary training. Okay, next slide. So although not every person develops intense emotional responses to stroke, those who do often have risk factors that make them more vulnerable. Some of the predisposing factors for anxiety or depression disorders are early onset after stroke, a poor social support system, a personal or family history of mental illness, or additional recent traumatizing events such as death in the family, divorce. Sudden laughing or crying for no apparent reason and difficulty controlling emotional responses, known as emotional lability, affects many stroke survivors. Inappropriate emotional behavior can occur randomly and end as quickly as it started. And it really only becomes a big deal when it's disturbing to the individual who knows they can't control it, or it's distressing or embarrassing to them. So the best we can do is forewarn families that this may be something that happens, and the stroke survivor as well, and just kind of work with it. This cognitive behavioral therapy has a considerable amount of scientific data supporting its use, and many mental health care professionals have training in it, making it both effective and accessible. The simplified example there of how it works in those 2 sentences is helping people to repattern their thoughts. If I can't do anything right, well, is that really true? I can do this right most of the time based on my prior experiences. Isn't that more true? And sometimes it takes a while to get those lines of thinking corrected. Okay, next slide. Oh, and I would be remiss to say, I'm forgetting my background as a registered nurse on that previous slide. Antidepressants and anti-anxiety medications may also be prescribed. But I say that as an afterthought because, of course, I think medications are far too frequently used when they're not needed. Next. So support groups, we all know the importance of being able to interact with a peer. And the National Stroke Association's website had a very nice portal with contact information throughout New York State. So I pulled one up, but you can pull them up basically by zip code. And stroke centers will often have a life after stroke type web page that has support links, group information, and educational resources. Support group information should be offered to survivors upon discharge from the hospital or at their neurologist's office. And social workers can be instrumental in providing individualized support. They can assess overall well-being, available supports, and assist with finding needed resources and in making needed referrals. Okay, next slide. The stages of grief, first published by psychiatrist Elizabeth Kubler-Ross in 1969, give an idea of what is commonly experienced by people who suffer great loss. On Death and Dying was a book particularly about how people face their own imminent death, but there is some application in the face of all personal loss. Over the years, however, many have put forth this grieving process as an orderly and predictable pattern that everyone will go through. And if you don't follow these steps, you aren't doing it right. There is no absolute right and wrong way to grieve. In my career, one of the biggest falsehoods I've continually encountered is that the grieving process is this, and it's 6 months long. And often people seem to want to limit others' grief to make themselves feel better or to return to what they consider normal. Well, Elizabeth Kubler-Ross told us in her own writings that her purpose was to validate feelings that someone might experience as a result of loss, not to prescribe what they must experience or the time frame needed to be normal. So there is, in fact, as great a variance of responses, perhaps as many as there are individuals, but we also can always find things in common. This puts us in a position to understand and offer support where people need it, without judgment and with kindness. Next slide. That completes my presentation to you today. If there's additional questions, I'd be happy to address them, or Christine may have more input. And as the last slide after this, I have a resource slide listed as well for where I got my information and where you can get additional information as well.
And I will send this out to everyone who's on the attendee list, so you'll have a copy of this electronically. All right, so if there are no questions.
Suzanne.
Yes. Go
Suzanne and Laura, I just wanted, this is Christine. I just wanted to add something. When we were talking earlier, when the question was posed, are there plans to develop more hospitals with the advanced stroke capabilities? I should have mentioned this at this point, but there was an initiative in New York State several years ago, and how they're trying to address some of that shortage in the rural areas is with telemedicine. I don't know if you've heard of that, but it's a way that it's an initiative that allows neurologists at the major hub hospitals to be able to provide real-time consultation and recommend treatment based on assessment of the patient and review of the CT scans over the internet, utilizing broadband connected personal or laptop computers, wireless equipment. So anyway, that is something that has been developed, and they are actively using up in the North Country particularly.
Great. That's
I just wanted to throw that in there.
Well, I want to say thank you to everyone. There does not seem there are any questions. This was very helpful, Laura and Christine. And we will look forward to your next presentation. Thank you, everyone.